Traditional manipulation versus activator for acute and subacute low back pain. It's always been true that chiropractors enjoy a good fight between techniques. Problem is, until recently, these have simply been opinion arguments, and biased ones at that. But more recently, attempts have been made to compare techniques, in particular traditional mechanical adjusting, such as side posture, to activator, and rightly so, considering the fact that activator and similar devices are the second most common approach used by chiropractors. In fact, a few studies have compared these two approaches, all demonstrating equivocal results with no winner. The study we will now review attempts to compare manipulation to usual medical care, but in so doing compares standard manipulation to activator because there are two manipulation groups in this study. The title is A Comparison of Spinal Manipulation Methods and Usual Medical Care for Acute and Subacute Low Back Pain, a randomized clinical trial by Schneider, Haas et al., published in Spine in 2014. This study was conducted between November 2010 and March 2013 at the University of Pittsburgh's Center for Integrative Medicine. Inclusion criteria for the participants were that they had to have a new low back pain episode within the previous 3 months, be at least 18 years of age, and have minimum levels of self-reported pain and disability. Exclusion criteria were patients with chronic low back pain, those who had previous chiropractic medical or physical therapy treatment for the current low back pain episode, radicular signs, contraindications to spinal manipulation, or current use of prescription pain meds. The outcome measures were standard, with an Oswestry Low Back Pain Disability Index and Numeric Pain Rating Scale. These were captured at baseline, 4 weeks, 3 months, and 6 months. Also, global improvement was measured. It's important to know where these patients started on average. The mean participant disability was 39.9, and the mean pain rating was 5.7, both moderate in intensity. Allocation was to one of 3 groups: a manual thrust manipulation group, or traditional manipulation, with 37 patients, a mechanical assisted manipulation group, or activator group, with 35 patients, and a usual medical care group with 35 patients, for a total of 107 patients. All participants were treated over the course of 4 weeks, and all participants received a copy of the same educational booklet with information about proper posture and movements during activities of daily living. What was common between the two manipulation groups was that they attended 8 office visits lasting approximately 15 minutes each, 2 times per week for 4 weeks. A single practitioner was used for the standard manipulation and a different single practitioner for the activator approach. For manual thrust manipulation, segmental levels for manipulation were determined by standard chiropractic methods of static and motion palpation, and only the lower thoracic, lumbar, and SI joints were manipulated. For mechanical assisted manipulation, segmental levels for manipulation were determined by using palpation and the activator method of leg length analysis only. No other element of the activator analysis method was allowed. And for the usual medical care group, a single MD, board certified in physical medicine and rehabilitation, assured patients that most acute low back pain improves on its own, and they were allowed to prescribe over-the-counter meds for pain. Participants attended a total of 3 office visits, an initial visit approximately 30 minutes, with follow-up visits approximately 15 minutes each at 2 weeks and 4 weeks. After the 4-week assessment, participants were free to pursue rehabilitation or manipulative treatment. So let's look at results, but start first with baseline scores. Baseline scores for pain for the traditional manipulation group were 5.5, for the activator group 6, and for the usual medical care group 5.7. Four-week scores for pain decreased to 1.9 in the traditional manipulation group, to 3.3 for the activator group, and to 3.8 for the usual medical care group. 3-month scores for pain decreased to 2.7 in the traditional manipulation group, to 3.9 in the activator group, and to 3.9 for the usual medical care group. 6-month scores for pain were 2.5 in the traditional manipulation group, 4.2 for the activator group, and 3.4 for the usual medical care group. For disability, the 4-week scores were reduced from 33.1 to 17.4 in the traditional manipulation group, 34.6 to 24.9 in the activator group, and 33.9 to 24.2 in the usual medical care group. Looking at global improvements, there was a 30% reduction in disability at 4 weeks for 76% of the traditional manipulation group, 50% of the activator group, and 48% of the usual medical care group. And a 50% reduction in disability at 4 weeks in 50% of the traditional manipulation group, only 16% of the activator group, and 39% of the usual medical care group. For pain, there was a 30% reduction at 4 weeks in 94% of the traditional manipulation group, 69% of the activator group, and 56% of the usual medical care group. And a 50% reduction in pain at 4 weeks for 76% of the traditional manipulation group, 47% for the activator group, and 51% for the usual medical care group. So what are the comparisons between groups in this study? The mean differences at 4 weeks showed significantly reduced disability for standard manipulation versus activator with an adjusted mean difference of 8.1. Comparison of traditional manipulation to usual medical care showed a similar result with a change of 6.5 at 4 weeks. For pain scores, the adjusted mean difference at 4 weeks between standard manipulation and activator was 1.4. Standard manipulation again showed a significant reduction in pain versus usual medical care of 1.7 at 4 weeks. So let's summarize. For disability, although the results demonstrated statistically significant differences in the two comparisons with traditional manipulation, the individual regressions at the 3-month and 6-month time points showed no significant differences. So what's important here is what happens at 4 weeks. Standard manipulation appears to improve patient pain and disability to a greater degree earlier than the other two approaches. This is reflected most dramatically in the comparisons of those with a 50% reduction in pain or disability. Again, although these differences between groups are lost over time, it would be clinically significant to patients that they improve quicker with standard manipulation when compared to activator or usual medical care, at least as demonstrated for the patients in this study. As usual, studies can't be perfect and will always have some limitations. In this study, there was no control group, so it's difficult to compare to no treatment or natural history. It was not possible to blind the patients or practitioners to the treatment approach, so various forms of bias potentially influence the results, which include the influence of patient preference. For those who use the full activator analysis approach in full spine treatment, not allowing use of the full system might be considered less valid compared to usual treatment for activator practitioners. As always, if a single individual is used to treat patients in a study, it's always possible that results are influenced by the ability and demeanor of that individual, so that extrapolation to all practitioners may not be possible. So although technique battles will likely continue, ultimately it's not about who is better or who wins. What hopefully will be gradually revealed is which approach works best with which patient group, considering factors such as patient preference, acuteness of pain, mechanical versus radicular pain, and perhaps age, gender, and other demographics. So instead of focusing on an egocentric practitioner concern, the focus should be patient-centered. What helps the patient in front of me, not which technique or techniques do I prefer as a practitioner? When we have answers to what works best for a given patient, customized to that patient, we can all celebrate.